I'm Jessie Strauss. I'm one of the EM attendings as well as the SIM division director. Today we're going to review how to do a cricothyrotomy using our QuickTrach. First, we're going to do a little review of the anatomy. So here we have an oversized model of the larynx, and just as a reminder, you have your hyoid bone followed by your thyroid notch, your thyroid cartilage, your cricothyroid membrane, and your cricoid cartilage. The landmark that you're looking for is the cricothyroid membrane. That's where you're going to be placing your cricothyrotomy. And then we'll come over to our mannequin model and we will identify the same landmarks. We will find our thyroid notch, our thyroid cartilage, our cricothyroid membrane, and our cricoid cartilage. I'm going to take my non-dominant hand and stabilize the larynx with my first and third finger. I'm going to use my second digit to help me identify and re-identify where the cricothyroid membrane is. Now we're going to take a minute to review what's in this QuickTrach kit. We have two sizes, size 2 and 4. 4 is what you would use for adults, and 2 is what you would use for kids. This is meant to be a little bit more similar to the Melker kits in that it is a percutaneous method of obtaining a cricothyrotomy. However, just some things to keep in mind is that it's a very small diameter tube. It'll be a little bit more difficult to get as good tidal volumes as you would with your traditional tracheostomy tube or an ET tube. It comes all pre-assembled with a 10 cc syringe, so you can sense when you're aspirating air, indicating that you're in the trachea. It has a protective stopper here. Generally, it's to prevent you from going too deep and piercing the posterior structures or hitting any vessels. It comes with a tube secure on it, and then it comes with this piece to hook up to the top of the tube and attach to your BVM or your vent. So now we'll review how to put this in. For some people, it might be more comfortable to be at the head of the bed or on your non-dominant side. Generally, we remain on the patient's right if you're right-handed. Using my non-dominant hand, I'm gonna reestablish my landmarks and support the larynx. So I'm gonna feel the notch, the thyroid cartilage, the cricothyroid membrane, and the cricoid cartilage. And this is where I feel confident that I'm feeling the cricothyroid membrane. Just a note, this technique can be both a little bit helpful if you're having trouble identifying the landmarks, but also if you cannot identify midline or any semblance of their cricothyroid membrane, it is probably not the best method to use as you can't extend any cuts or troubleshoot once you're in. So when you have located your cricothyroid membrane, you're going to place the needle in midline at a 90-degree angle while aspirating. So once you get air, you're going to drop your angle to 45 degrees. This is where you would remove the stopper, and then you're going to advance only the tube. Your needle comes out, you're going to attach the tube, and you're going to attach your BVM here. You can then secure your tube and proceed with any post-cricothyrotomy or post-intubation care, such as a chest x-ray to confirm placement, an OG tube, and calling for respiratory therapy.